Welcome to our most recent Tush Talk. I'm Kathleen Legault, Patient Support Specialist at Colorectal Cancer Canada. Today, we will be discussing metastatic colorectal cancer, advances and future directions. We have the pleasure of being joined by Dr. Ronald Burkes. Dr. Burkes is Professor of Medicine at University of Toronto and Medical Oncologist at Mount Sinai Hospital. He has vast experience in managing and treating individuals of all stages of colorectal cancer. Thank you for joining us.
Thank you, Corinne. It's a pleasure to be here.
So I'm going to start off with some basic questions. So can you explain to us what is metastatic colorectal cancer?
So metastatic colorectal cancer implies that the cancer has spread beyond the local region of presentation, whether it be in the rectum or different parts of the colon. So it has spread beyond just a surgical excision, for example, of the disease. So spread to the liver, spread to the lung, spread to lymph nodes that are beyond the local site of disease, or spread to the lining of the abdominal cavity that we call the peritoneum.
And is it the same cancer that is in the other regions? So do we still call it colorectal cancer even though it's in the lung or the liver?
Yeah, I know sometimes patients think, well, now it's lung cancer, but no, it's still colorectal cancer that has spread to the lung or to the liver. So it's not liver cancer, it's not colon cancer, it's not bone cancer. The biology of the tumor under the microscope and how it behaves is still from the original site within the colon or rectum.
Another question we often get asked by patients is, once they go through investigation, once we have collected all the information from their biopsies and the different investigations they have done, doctors propose that they provide their case to a tumor board, but we don't necessarily understand what that means.
So a tumor board is basically getting multiple opinions all at one time. So it's comprised of a combination of medical oncologists who treat cancer with chemotherapy or immunotherapy or drug therapy, radiation oncologists, they're the ones who do radiation therapy, as well as surgical oncologists. And those surgeons include colorectal surgeons, will include liver surgeons, or we call them HPB surgeons, hepatobiliary surgeons. So it's a combination of multiple individuals across different sites who get together and present cases. Generally, it's cases that we ourselves have questions, how is the best way to manage? And sometimes people are brought back to tumor boards on multiple occasions because today managing colorectal cancer can be complicated, and so requires the input of as I say, multiple different subspecialists. Tumor boards also comprise of radiologists who review the scan results with us, and sometimes our pathologists attend as well to review the pathology of that particular tumor. So basically, it's a multidisciplinary approach to patients where many of us all get together and come up with a consensus how we think that patient should be managed.
Super interesting. So it's a good thing to be referred to a tumor board for a patient because you'll have multiple opinions as well.
Yeah, now eventually we try and come to a consensus, and someone records what the ultimate decision has been. Sometimes you don't come to a consensus, sometimes there is no consensus, and so those of us who are directly involved in the care of that particular patient will end up emailing each other to say, okay, what do you think? What should we ultimately do? But in general, we try and uphold what the consensus is, if there is a consensus. But even there are times where I might not present a patient to tumor board necessarily because it's specifically a medical oncology question, and so sometimes there's a number of us across the country who are kind of on an email highway with one another, and we'll sort of give a review of a patient and ask other people, other medical oncologists in different parts of the country what do you think? And, there's usually 5 or 6 of us who are actually on this kind of highway, and sometimes we all have the same idea, sometimes we don't have the same idea or different opinions, or sometimes it's something, oh, maybe I didn't think of doing it that way, I could have done it this way. Not that there's a right or wrong way. Sometimes there is a right or wrong way, and hopefully we're only choosing the right way. But sometimes people come up with other ideas. Say, maybe we should do that first rather than this. So
you've been doing this for quite some time.
1985, I started in practice.
How was metastatic colorectal cancer treated when you started your career?
So, I was just talking about this with my residents this week, actually. When I started in 1985, we were not always, but quite frequently debating chemo versus best supportive care. In other words, is it even worthwhile treating patients? Because the benefit of chemotherapy was relatively minimal. And the toxicity of the chemo we use, or the side effects, weren't terrible for the most part. So it wasn't as great a deal of a discussion as it was in other tumor sites, such as lung cancer, for example, where we really were debating, are the side effects worth the very small or limited benefit? When I started in 1985, we had one drug available to us, and that's 5-FU or 5-fluorouracil. We were adding a vitamin to it called leucovorin or folinic acid, which made the drug work better. Believe it or not, it is still the backbone of the chemotherapy that we still use. How we give it is different. What we use it with is different. But when that treatment stopped working, we had minimal to no options of treatment. The average survival of stage 4 or spread of colorectal cancer in 85 was approximately 6 months. That has more than quadrupled today. And I'm sure we'll get into some of the things that have changed over the years. But things are very different in 1985 than what they are in almost 2023.
And we'll move forward a bit in time. Like in the last 10 years, have you found that there's been advances in care?
Clearly, there's advances in care. We have multiple drugs now. We have, first of all, we have first-line therapy. We have a second-line therapy. We often have third-line therapy. That's another issue because it's not always available to all patients, because not all drugs are funded in all provinces. So beyond first and second-line chemo, we don't always have other options that are funded. We have now phase 1 programs, for example, at Princess Margaret Cancer Center. They do phase 1 or testing new drugs. So those are available to patients. And then, of course, we're into a whole new era of molecular markers and immunotherapy and testing tumors for various markers that might be actionable with newer drugs. So things have changed quite dramatically. Just the fact that the average survival of metastatic colorectal cancer today is now approximately 3 years and may even be greater for some patients. The surgical approach to patients, even when the cancer has spread, has changed. So, when I started in 1985, we were not taking out tumors that had spread to the liver or spread to the lung. We are now doing that routinely. At UHN, I'm not the surgeon involved, but no, they have now a liver transplant program for patients with metastatic colon cancer to the liver. For patients who aren't eligible or are not candidates for resecting the tumor within the liver. So though all of those have really changed how we think and how we practice, even the use of localized radiation therapy, we call that SBRT, is new. The use of radio frequency ablation by our interventional radiologists, where they try and burn the tumor. Those are other options. So lots of things have developed since 1985 that we never even thought of. And I remember even when we started taking out tumors in the liver, once it had spread, the initial was if there was only one spot, they would take it out. Then they got brave and said if there's up to 4 spots, we can take it out. Now, there is no number In fact, I've heard the liver surgeons say it's not really the number, it's how much normal liver we can leave behind, because obviously you have to leave some liver behind. And fortunately, the liver, regrows within, 2 to 3 weeks. So you can take out probably 20% of the liver and people are still going to live normally while that liver is regrowing. So it's how much can you leave behind safely, which really is the key here today. So those are all things that evolved over many years.
So we touched a bit how certain of the treatment is different, but like what differentiates the treatment for early stage patients, so stage 2, 3 versus a stage 4 patient with metastatic cancer?
So for stage 2 or 3, of course, the primary therapy is surgery. Now I'm excluding rectal cancer because it's a whole different area altogether, and I don't think it's something we can get into. It's complicated and evolving, and times are changing with rectal cancer. So let's just stick with colon cancer. The primary treatment for colon cancer is to take it out, and we do know that there's a risk of it coming back. And so we often give chemotherapy, what we call adjuvant chemo or preventive chemo post-surgery. That depends on the stage, if it's stage 2 or stage 3. So the differences between 2 and 3 is stage 2, the lymph nodes around the cancer are negative. Stage 3, the lymph nodes around the cancer have cancer cells in them. But even within stage 2, there are sort of different risk categories. So there's a low risk group, and it's defined by a number of different clinical factors, as well as things that the pathologist sees under the microscope that they report when they give their pathology report. And if those features are present, we often do recommend giving chemo as well as prevention afterwards. If they're not present, we do not give chemo. For stage 3, the standard of care is to give chemotherapy. And it's usually combination chemotherapy with a combination of different drugs. But even that has evolved in the last 3-4 years. The standard of care was 6 months of chemo. There's now lots of data that for certain subgroups of stage 3, we only need 3 months of chemotherapy and not 6 months. And that minimizes the side effects as well of the chemo in terms of potential long-term side effects that we can see with, one of the particular drugs that we call oxaliplatin, which can affect the nerve endings and cause what we call a neuropathy, numbness and tingling. Frequently, it gets better after therapy, but not in everybody. So if you can give less of that drug, you have less neuropathy. And the question was, do you get the same benefit in terms of survival? And the answer is, in certain subgroups, you do. There's no difference in outcome, so we've reversed to 3 months of chemo. So that's stage 2 or 3, where the goal of treatment is the cancer never coming back again. For stage 4, of course, our approach is very different. Our approach up front basically is, is this someone who you can operate on and take out the tumor that is spread? Is it someone who, if you give treatment to, you might be able to shrink the cancer down to a point where the surgeons can take it out? And then sometimes there's the last group, which is the group that no matter what you do, surgery is not ever going to happen. So if it's spread to the bone or multiple sites, the chances of us being able, surgery is really not the mainstay of therapy. It's the goal of therapy there is make people live as long as possible and as well as possible. So quality of life and quantity of life is our goals. Now, of course, those are maybe our goals. Patients have different goals. So that's
absolutely, and they're taken into consideration when a treatment is advised.
Always.
And it's important for patients to verbalize what their objective is when they meet their oncologist.
Yeah, I mean, for most people, they want to live as long as they can. And age doesn't matter. I mean, there are people anybody at any age wants to live as long as they can. But some people, when they're really sick, just say, you know what, I've had a good life. I've lived a long life, and quality is more important than quantity. What some people forget, though, is that the cancer also causes side effects. And sometimes by treating the cancer, you actually improve their quality of life. And in fact, that's been shown years ago when we were doing these studies of chemo versus best supportive care. And best supportive care basically meant giving, and still does, means doing everything but giving chemotherapy or systemic therapy. So whether it's pain management, constipation management, local radiation for pain control, things like that, that's best supportive care. And we still do that. And we do that as part of systemic therapy. In fact, we have our palliative care physicians work with us. And I think it's something that's important. I mean, a lot of patients have this concept of palliative care being, well, my life is over, it's end of life. And that's not at all true at all. They're very well versed on pain management, support. I think it's better to call them supportive care than palliative care. Maybe that was a misnomer from years ago that should have been changed. And in fact, there's studies now that show that people who get palliative care early on in their management actually live longer than those who you wait until, okay, there's nothing left for me to do, let's send them to the palliative care doctor. So we're fortunate that in my clinic, I have the palliative care physicians working with me in my clinics. So I get them involved early. Obviously, patients, we still have some people who still think palliative care is end of life, and I don't want anything to do with them yet. But I think it is a good idea to get them involved. So that's those are our goals, depending on stage 2, stage 3, and stage 4. There are different goals as well, and different plans of management. And so you have to kind of look at what, the different groups of patients, even in metastatic disease.
Some of those more targeted treatments, some of them that we hear are immunotherapies. We're hearing a lot about them, but they still remain pretty limited to a certain segment of the population. Do we see in the future that they'll eventually become more available to more patients?
I hope so. I mean, the population right now, and this is what, unfortunately, the media isn't very good at this, because they don't report, when the data came out from the oncology from ASCO in the spring showing this 100% response rate in rectal cancer, I'm sure you're very familiar with this. Before I even returned to Toronto from Chicago, patients were calling me. And because all they heard was this 100% response with immunotherapy. They didn't hear, in fact, it wasn't reported. I mean, I saw CNN and I saw all these articles. Nowhere in the articles did they talk about this very small subgroup of patients for whom immunotherapy actually works. We call these patients MSI high, which is microsatellite instability, which basically looks at the way the DNA repeats itself, very simplistically, I'm saying this, of course, within the cancer cell. And we have two groups. There's MSI high and there's MSI stable or low. And it's the MSI high population, which unfortunately only makes up 5% of all colorectal cancers, for which immunotherapy works. And now we have studies to show that in patients whose cancer has spread, giving immunotherapy is superior to chemo and is now the standard of care for that subpopulation of people. There have been studies that try to make what I like to say are cold tumors hot by making them more responsive to immunotherapy. But unfortunately, to date, those studies have been negative and not, that we haven't been able to convert a tumor for which immunotherapy wouldn't work to a tumor for which immunotherapy does work. Hopefully that'll change down the road, but for now, the immunotherapy is specifically for that small subgroup of patients. There are now, there was another study at the European oncology meetings a couple of weeks ago in Paris, looking at locally advanced colon cancer and giving immunotherapy, and the response rate was phenomenal. I mean, it was just unbelievable. It was, a presidential symposium presentation. Again, small numbers of patients in both those studies. It's not yet ready for prime time. We need to see more randomized trials, but the early data, even for early stage disease, that maybe immunotherapy will be moved up to earlier stage disease. So I think the future is bright. It would just be nice if we could open it up to more than just that 5%. Now, in the adjuvant setting or early stage disease, about 15% of people are MSI high. So it's a little bit different in early stage than it is when it is already spread, but still a relatively small number. So immunotherapy isn't for everybody. And I wish the media would be a little, the media makes our job a lot more difficult.
And are there other treatments that are in the pipeline coming, or other evolution that is happening in treatment of colorectal cancer, like in the near future, that you can see or have?
I don't think there's anything that's on the horizon imminently. I mean, we now are doing routine or requesting for a lot of molecular testing done. I think the future will be that we'll be routinely doing what we call next generation sequencing or NGS testing of tumors, and being able to detect multiple different mutations for which we will have specific drugs. I think that's where we're headed. It would be nice if this kind of testing was just done upfront on everybody, so we had that available. So one, for drugs that may be in the pipeline, or two, for patients being eligible for clinical trials, testing drugs that are targeting those specific things. So is there anything imminently? Not that I'm aware of. I mean, other than studies are being done and testing new drugs to look for these targets. The problem is that, our funding bodies like to see randomized studies being comparing what we normally would have given to something that's new, and seeing, is that new thing superior to the old treatment. The problem is that some of these, abnormalities that we pick up on this molecular testing are a very small percentage of patients. So to get randomized studies is not easy, because you're not talking about a lot of people on a clinic that would be eligible for a clinical trial. It's not easy to do. The MSI high population, which represents 5%, it takes a global study to collect enough patients to be able to divide them into two groups that are randomly assigned to test. The theory is the new drug superior to the old drug. Sometimes if you have a mutation that's only in 1% of the population, you're not 1% of the tumors, you're not going to get a randomized study. And sometimes just the proof of concept is what really, the funding bodies, I think, need to change their thought processes. That's a whole other discussion.
That being said, my understanding is there is a huge importance in trials for late stage cancer. It's for the more information we gather, the better insight we'll have on the future.
Yeah, and I think it's important to try and encourage people to be, participate in clinical trials. I do clinical trials, so obviously that's part of what I do, and part of what I think is important, because it's the only way we're going to learn whether drug A, new drug A is better than old drug B. And it's the only way we're going to be able to prove to our funders that, this is the treatment we should now be giving. Part of the problem, though, is, in terms of the cost I'll just mention it briefly, is that most of the time our new drugs aren't necessarily replacing our old drugs. They're changing the sequence that we give the drugs in. So it's not necessarily that the overall cost is changing. Yes, these new drugs tend to be a lot more expensive, but we're still at some point, unless these new drugs induce a cure and we never have to use all our other drugs, most of the time, we're ultimately going to be using the chemotherapy, or even, for example, sometimes we're using combinations of chemo plus, the new drug. And we've seen that with, our what we call our EGFR monoclonal antibodies, panitumumab and cetuximab. We don't give them alone up front. We give them with chemo. So it's chemo plus that. So it's just that it's just the way things tend to go and sequences change. But maybe one day we'll find the magic key, and it'll be one treatment for X amount of time, and cancer will never come back.
I'm going to change gears a little bit. I think we addressed it a little bit at the beginning when you were talking about supportive care, but are there any other ways that the care team can support metastatic patients? We often talk about the emotional or the psychological stress about being a metastatic patient. Is there any tools that are out there for these patients to help, deal with some of these challenges?
Well, certainly, I think most clinics, certainly ours, we have, as I mentioned, we have the palliative care team that's involved, and they're in the clinics. They see our patients. We get them involved early, assuming the patient's agreeable. We have social workers who work with us. We have nutritionists who work with us. And we actually have a dedicated psychiatrist who sees pretty much only cancer patients. So, I think most clinics do have those kinds of supports. Some of them aren't as readily available as others, but overall we do. Then we have, Colorectal Cancer Canada, which supports, people and has a lot of, resources that patients can contact. And so, yeah, there are quite a few things that are out there for people. Canadian Cancer Society is out there, but I think specifically for colorectal, I think colorectal cancer does an amazing job, and I think that the resources that you have that can help patients are tremendous. But within our own clinic, we have a lot of we certainly have a lot of resources that we can back up, use for our patients, and our social worker will see our patient in the clinic. We have nutritionists in the clinic. We have all of those are important. And then finally, we have I think most most hospitals now or clinics or cancer centers will have a drug navigator, maybe more than one drug navigator, because the amount of paperwork to get access to certain drugs. So, for example, some drugs are available on special access programs, so they're not funded yet. But even though everyone, so a lot of people think big pharma is bad, they give us a lot of drugs for free for patients. Now, it's not an unlimited supply forever, but until drugs that are most likely going to be funded, but we have a pretty good idea what drugs will be funded, and they will make them available on a special access program. So we have drug navigators who can access that. We have our drug navigator is great in working with the insurance company. So, I hate to say it, there is a two-tier system. Those people who have private drug insurance can sometimes get access to drugs that aren't funded. These are oral drugs predominantly, but not always. So, they can navigate, does your drug plan pay for this drug or not? So there's lots of things, supports that are out there for people. I think everybody has a drug navigator. Couldn't see never working without one. I mean, when we did at one point, I could never see today not having that individual.
It's such a good resource. And you also bring up a good point. I feel that a lot of patients that do participate also in our support groups that we offer here at Colorectal Cancer or at other cancer associations find such a good benefit from participating and discussing with other individuals that are going through the same thing. Yeah. Just having that real life experience that's shared is such an advantage, and they come out of these meetings with such a another view or another vision of their current situation. I wanted to think.
Yeah, and then I think just there's survivorship programs. I mean, I'm not far from Princess Margaret, kind of very close. So, they have a survivorship program that people can get referred to. And now this whole, of course, the incidence in young adults, colon cancer is increasing. And that's a very specific group that I think needs to be targeted as well.
Thank you incredibly, Dr. Burkes, for participating with us today. Having the opportunity to talk to you has brought up so much great information, and I'm sure our patients will enjoy, and family members will have additional information to go forward with. and we look forward to talking to you in the future.
Thank you. My pleasure, and absolutely have a good day.
You too. Goodbye.
Bye bye.